Good morning. My name is Bjorn and I am working for the Danish Society for Patient Safety, and I will speak about the Global Trigger Tool that the IHI has developed. And this guy is Lord Kelvin, and I always show a photo of Lord Kelvin when I speak about the Global Trigger Tool because he apparently said that you cannot improve it if you cannot measure it. Where did the clicker go? So, since I'll be competing with the lunch break if I don't end on time, I will skip ahead some of my slides. So I'll not be speaking in details about other measures of patient safety, since we've heard that already from Jonathan and Maxine. But I'll speak about the performance characteristics of the Global Trigger Tool, and I will also present studies, preliminary studies from a study that we have done on the Test-Retest Reliability of Global Trigger Tool. So the Global Trigger Tool uses a definition of harm as unintended physical injury that results from the activities we carry out in healthcare. And it is a structured medical record review. Usually it will be 2 nurses reviewing a random sample of 20 records per month, looking for triggers, and the trigger is just a signal that this patient might have been harmed by healthcare. So it could be a raised lab value, it could be a note in the medical record that the patient was found on the floor, it can be a note that the patient was transferred to the ICU. So the nurses spend a maximum of 20 minutes looking for triggers, and if they find a trigger, they do a more detailed review of the record to see if this patient was actually harmed. They then discuss their findings with a physician supervisor who has to confirm that this is actually an adverse event, and who will also help the team determine the severity, ranging from temporary harm that needed closer monitoring of the patient, and all the way to harm that led to or contributed to the patient's death. Results are then reported typically as adverse events per 1,000 hospital days, or as the proportion of patients harmed, and also the event severity is reported. Many hospitals also eventually end up having some kind of clinical categories that they put the different events into. So they have infections, they have falls, they have surgical complications. So I will present a few studies, none that I've done myself, about the measurement characteristics of the Global Trigger Tool. I'll not talk a lot about the inter-rater reliability because that is actually the least interesting part, and I will get back to why I think that. And then I'll discuss the results of our own study. So we do have a problem here, and that is that we lack a gold standard for measuring patient harm. So we do not have another measurement that we can hold this against and look at its characteristics. So Klassen took a look at the detection rate, used a random sample of close to 800 records from 3 large American hospitals, and used 3 different screening tools to identify adverse events. The Global Trigger Tool, the ARC patient safety indicators, which is a national American indicator system, and the voluntary reporting systems in the 3 hospitals. And then at one of the hospitals, they also had a team of physicians do a very detailed review of all records for patients, and looking at administrative, financial, longitudinal health data, and used that as a gold standard. And here's their findings. So EFGHI is the 5 levels of severity of harm used by the Global Trigger Tool. E is the least severe, and I is the most severe. And what you see from this slide is that the Global Trigger Tool identifies many more adverse events than the 2 other methods. I'll not spend a lot of time on this slide, but it is interesting though, because they also used the gold standard established at one hospital the local review, measured that against what was found by the Global Trigger Tool, and used that to calculate sensitivity and specificity of the tool. There's a kappa value of 0.94, which is almost perfect agreement between what was found at the local review and what was found by the Global Trigger Tool. Another study was done, this is a pilot study done by the Office of Inspector General. It's an office of the US Health and Human Services Department. They did this study because Congress had asked them to find out how many Medicare and Medicaid patients were harmed and what was the cost of that. So they took a random sample of close to 300 records using 5 different screening methods to identify adverse events. Again, the Global Trigger Tool, the ARC patient safety indicators, another set of indicators developed by the ARC called present on admission indicators. A present on admission indicator is a code that you add to every diagnosis you make. So if you make a diagnosis of renal failure, you will code whether that was present on admission or not. And the idea is that if it was not present on admission, we might have caused that. They also carried out interviews with patients and relatives, and again they looked at the hospital voluntary reporting systems. The 5 methods combined identified 120 adverse events. And as you see from this slide, the Global Trigger Tool identified around 80% of those. And that's an overlap here, that's why there's no total. Present on admission indicators also did a pretty fine job, but the other didn't find that many adverse events. So, inter-rater reliability. Why do I not think that is very interesting? Well, what they do is they look at inter-rater reliability at the level of the individual medical record. The tool was not developed to capture all instances of harm, so therefore it should not be surprising that there is not necessarily a complete agreement. And also, that is, the individual record is not the sample. The sample is really a number of records over a number of months. But anyways, this is what they did. They looked at 2,400 records from a period of 5 years, and also with a very low number of records per hospital, only 40 records per year. And then they looked at reliability between internal and external reviewers and experienced versus the internal and external reviewers. It's a huge article with table after table, figure after figure. So I have just quoted their main findings here, which is that there's a moderate inter-rater agreement as measured by the kappa value. Another study that looked into that, it's from the Mayo system, looked at 1,100 records. It's not exactly clear from the article what time period, and they looked at internal review only. And they found, again, kappa values of around 0.4 to 0.6, that is moderate agreement between nurses. This is a completely different kind of study. It's from the 5 Danish hospitals involved in a national demonstration project that the Danish Society for Patient Safety run with assistance from the Institute for Healthcare Improvement. So these hospitals have been using the Global Trigger Tool for a number of years, and what we see is that there's a substantial variation in the adverse event rate that they find. Even though they are actually pretty similar, they have the same kind of clinical departments. They are of different size though. So we think that the variation might actually be due to the measurement process itself and not due to the clinical processes taking place at the hospitals. This study sets forth some recommendations for implementing the Global Trigger Tool, and basically it's about training the team and making sure that they have an ongoing discussion to make sure that they keep agreement about what to include and what to exclude as an adverse event. So, what to make of all this? At this point, I think we can conclude that the Global Trigger Tool is far superior than other methods at detecting the presence of an adverse event. It has an excellent sensitivity and specificity, and there's a moderate to good inter-rater reliability at the individual medical record level. Then this happened. So this is one of the 5 hospitals in the Safer Hospital program. So it's a hospital that is getting a lot of assistance and pouring a lot of resources itself into improving care. So we didn't really expect to see this. So this is an adverse event rate that climbs from just below 60 to just over 100. We had to look into that. So what we decided to do was, instead of doing all this individual record level stuff, we would look at the test-retest reliability, look at the team's ability to reproduce the adverse event rate for a given time period. So they had been doing the review as an ongoing effort from January 2010, and are still doing it actually. So what we wanted to do was to look at the baseline measurement that is from January to June 2010, and have them review that period again on a new sample. And also for the latest period, at that point when we planned this was from October 2011 till March 2012, make a new sample of 120 records from that period and see what happened. So what we expected to see was that there might be some learning curve effect in this. When we spoke to the team, we got the impression that they had become actually better at picking up and at finding adverse events. So we would expect, when looking back at the baseline period, January to June 2010, that in a new sample from that exact same period, the team would now find a higher rate. But we would also expect that measurement had reached stability, so that if we looked at the latest stable period, we would not find a significant difference. And I know that on the relay screen you probably cannot see the median, but you can see it up here, I hope. So this is the first measurement of the baseline period. So this is the original measurement done back in 2010. And the sample contains 120 records. They found a median adverse event rate in that period of time of 56 events per 1,000 days. Then we did the new measurement. So this is another 120 records from that same period of time, but now we had them do this in July of 2012. And indeed, the rate was higher as we expected. I don't know if we expected it to be that much higher, but it's actually close to double the rate. So a new median of 104. So this is period 2. This is October 2011 to March 2012. It's the original measurement done real time once a month. A median of 109, and we would now expect, having them look at a new sample from that same time period, that they would find a harm rate that did not significantly differ from that. And then they found this, a median of 146. And this is not just a chance occurrence. They are actually from 2 different populations. These. So, what to make of this? If we want to use the tool to monitor our improvement over time, actually the difference between the 2 latest measurements is greater than the difference we're trying to accomplish in the project. Well, another way is, of course, to look at data in another way. So we did that. Much better. So if you look at admissions, proportion of admissions with harm, So this was adverse event rate per 1,000 hospital days. This is now the proportion of admissions that have at least one incident of harm. The bottom part is still the baseline period measured to the left first time, measured to the right the second time. We still see an increase that could confirm that there is indeed a learning curve here. And the top two graphs show the last period, period 2, measured to the left for the first time and to the right for the second time. And now there's no difference. We still wanted to learn a bit more. So we looked at the distribution of the severity. So again, this is the scale of EFJIHA, E being the least severe and I being the most severe adverse events. And please take a close look at the dates, because they're kind of confusing the way they are ordered here, but that's just to keep you awake. What you see is that the difference can be explained completely by a greater number of the least severe events. There are, of course, limitations to our study. One is that this team actually does not do Global Trigger Tool the way they're supposed to. They never consult with the physician. They just carry on. We also had them working intensely for 2 weeks' time to look through these 240 records. Usually they look at 20 records one day every month. Now we had them look at 240 records over a 2-week period during summer in a small room. They said to us afterwards that they felt that they were actually becoming tuned in and had this experience themselves, so that they were actually getting better at picking up adverse events. We also, and I'm quite embarrassed to have to admit this, but we also did not think of randomizing the order in which they did the retest. So we cannot tell you whether they act, and since they did the retest in the order that the records became available to them, so there's a risk that they have actually also had some kind of timeline in there. And it's a small sample. We only have 120 records per data point. So at this point we can conclude that detection rate, even with an experienced team that has really received a lot of training and support, may change over a short period of time. And I think the most important thing is that if you want to use the number part of the Global Trigger Tools, because you'll get a lot of qualitative information that is really useful. I haven't talked to a hospital using the Global Trigger Tool that has said we cannot use that. They will always tell you that they can use the qualitative information. But if you want to use the number and track that over time, it's really important to have underlying measures of process and outcome to actually qualify that measurement and to give you the contextual knowledge to understand it. Right now I'm not really sure if we can use it to monitor our adverse event rate over time, and I'm happy to conclude, this is a classic conclusion, further studies are needed. Thank you.
All right, thank you. We do want to reserve enough time now for some questions and answers, so Kate and Lizzie will be working the room. If you do have a question, please address it to one of the individuals, to either Maxine, to Brian, or to Jonathan, and that way we can be focused on our talk. Over here, let's start in the front row, please, Lizzie. And then the second question, maybe Kate can prep that person. If there's another question, please raise your hand. We'll get you the microphone right now while we're addressing this question.
Marius Paravan from England. For question for the last speaker. I think there is another classical quotation, you may know it. If you torture data long enough, it will confess to everything. So obviously, torturing your data on the median, you've got the result that eventually shows that the global trigger tool probably is still to be used. What I'm not sure, have you retested the inter-observable reliability second time when you analyze it? Have you seen any progress?
I didn't get that.
So when you've tested the way your team works in terms of achieving good inter-observer reliability first time, have you tested this the second time to see if the difference you've seen can be explained by a change in inter-observer reliability of using the tool by the team?
No, what we have seen is that we think it can be explained by they picking up more of the less severe events. Also, when we look at the clinical categories, they suddenly find a lot of gastrointestinal complications that we have no reason to believe not were there before, so they have probably become better at picking them up. And also, the hospital has become better at documenting it. I didn't go into that, but we can also show from the data that there's an increase in the documented adverse event rate. And whether that is a clinical or a more administrative thing, I can't tell you.
So that's a major factor, better data quality to analyze. Excellent, thank you.
Now, when you did your reviews, you used nurses, you said. You didn't use, a lot of times when we set up the Global Trigger Tool originally, the idea was to get, say, 2 reviewers, either we have used pharmacists, nurses, and physicians, and we've done different combinations of should the nurse and the pharmacist do the review and then the doctor confirm it, or did the doctors and then look for other confirmations. So we've actually done a number of different studies that several of us have published at times on what combination works best. And this is one. They all have utility, and it's something you need to sort out. What level and what individuals are you actually going to use to do this confirmation? So the CAPAs that we've run on are on various combinations. Any other questions? Please, yes? Kate, back here. Hi.
Hi, Tim Kane, Portsmouth. It's a question for Maxine. What was it that made you choose the 4 indicators, i.e. pressure, ulcers, falls, urinary tract infections and VTE, and are you going to modify those at all for the sequin targets? Because I see an awful lot of harm, morbidity and potential adverse incident related to medication, missed medications and medication errors in my patients. And I think this needs to be a dynamic issue rather than a static thing. And the other thing I'd say is it's slightly sad that pressure ulcers are something which a few years ago didn't really occur. And I'm also seeing that as a massive issue in some of my patients.
Yeah, thanks, Paul. So how did we choose what we were interested in? It was a multifaceted and long conversation, actually. So one of the things we did was we went to the plethora of safety programs that were actually up and running and said, what are you hearing locally is the big issue, and what would you do next? And actually, those 4 things were essentially on a Pareto, the top 4. We then looked to see what kind of impact those 4 things were actually having from the evidence that we had. So we went to all the available data sources, the HES data, which is our administrative data. We went to adverse incident reports, and we went to Global Trigger Tool information, actually, where it existed. And we confirmed that our best estimate was that these were highly prevalent harms, which really were actually going to be important to us into the future. So we then did a second bit of conversation with patients and said, is this meaningful to you? And we got back a wholehearted yes, because they were saying, yeah, we understand what this is about. And we also did a piece of work to say, well, are these issues only hospital issues? Because if they're only hospital issues, then they're highly likely to be something that is already being worked on hard and are not relevant for the future. Not that they're not relevant, but what we wanted to identify was whole system issues. I think the thing that we were also keen to do was to make sure that, and this is quite controversial, I think, was make sure that actually you couldn't fix this if only the hospitals did it. So it was actually a pressure point for the whole system to work together. So I think you can challenge me, but I think it's very difficult to fix pressure ulcers if you're just working as a hospital system, because you get that constant revolving door scenario. What we've learned since is that bit about they're interconnected and they affect the same patients, and the patients that are susceptible to pressure ulcers and falls, etc., are highly likely to be the ones that are dehydrated, are highly likely to be ones that are susceptible to sepsis, delirium, etc. I think that's interesting, and it requires further exploration, because I think what we've tended to do in the past is measure one thing, like pressure ulcers, almost in a silo, and I think we're getting a much broader sense of the interconnected nature of harm, which is actually starting to surface in other settings. For example, Peter Pronovost is doing some work in the ICU on the interconnected nature of harm in the ICU. And I think that's interesting. So this idea of four things seems to have resonated with people. Also, the absence of the four things, the harm-free care bit. And to your final point, medications, absolutely. So Nick Barber and I were having a conversation about this on the stairwell outside, which is the beauty of this conference, about this yesterday. And I was saying, if any of you ski, this is the black run of improvement. So it's a really challenging and hard thing to do, and many of you will be in the middle of doing this. So nationally, we wanted something that we knew was amenable and that was responsive at the highest level to change. So we went to Kaiser, actually. I asked Kaiser in California whether they'd seen change, and they had. So that was how they were selected. In terms of the future, I think you could take the four things out of those four boxes and put in whatever you choose. And the future will be that there will be a shell which you will then be able to build in your definitions, your things that are important to you into a safety thermometer. So in other words, like a drag and drop, you'll have an operational definitions library and you'll be able to drop it into a safety thermometer, which I think will allow people to use it in a much more applicable way in their local setting. So this is just the start, really. And it feels like that there's been a few hurdles to get people into the concept of a temperature check rather than a whole system measurement process. But now that people are here, there actually is quite a pull for it. What I would caution people against is thinking that this is the way to quickly and easily measure safety, because it doesn't do, obviously, the case note review, and it doesn't do the much broader scoping exercise, and I know that you already know that. So thanks for your question.
Can I just reiterate the thing with missed medications? I've skied to quite a high level. Missed medications is a blue run, not a black run, to prescribe on a chart, and for those medications not to be given to a patient I find abhorrent. And as I've reiterated, this causes an awful lot of morbidity in healthcare, and I really hope that this can be brought through. We have a pilot medication safety thermometer which has emissions on the very front page, and we've tested it on about 80 patients, and we're looking at about a 12% emission rate in the data set we've got at the moment, and the plan is to scale that across the north of England. So we will be starting to collect data in this way on medication safety to complement what's already happening in pharmacy practice, where there's a lot of work. And I would say have a chat with Nick down the front here, because he is like has the Bible of literature around medication safety. So let's have a conversation after the session.
We have a few minutes left. Any other questions, comments, reflections? One right behind you there, Kate.
Hello, I'm Richard Edgeworth from Springfield Consultancy, and I just wanted to comment on the discussion just now and particularly highlight my own experience from going into a variety of clinical areas in all sorts of settings and making a point of not talking about national initiatives. And the starting point has to be what's important for the people in that clinical area. But I'd spread that beyond that to the people at professional level, but also talk to the patients and carers and families within that clinical area who are receiving treatment at that particular time. That snapshot is a very vital, important access route to beginning that conversation to find out what's important. And it may be, as Paul identified, something to do with medication. It may be something to do with something you weren't expecting to hear about. If you then start looking at that as the issue to be dealt with, that is the foothold into getting involvement and engagement of patients and families and staff in an initiative, beyond which you can then start talking about the wider experience and learning from the national initiatives and more mind-boggling research, and there's plenty of it. But my approach is to keep it simple, engage with the clinicians at all levels within the arena, and that's your starting point. And once you get that, it becomes very exciting.
I completely agree.
All right, thank you. Let me turn to our other colleagues up front. Charles, Susan, Nick, do you want to add any comments on any of the session? All right, well, thank you very much for coming. Enjoy the rest of the conference. Our speakers will be around if you wish to talk to them. Thank you. And thank you, Liz and Kate.